Hi everyone, I am Dr. Sagar Sahu and welcome to Vet Surgery at Teach. So today I welcome you to the last lecture in the series Orthopedics. Okay, in the BCI syllabus, the course is actually Orthopedics and Lameness. Okay, what we are discussing or what we are learning is basically the Orthopedics. There is a portion Lameness, there is canine lameness, there is bovine lameness, and there is also the equine lameness. Okay, lameness mostly deals other than fracture. Okay, all the orthopedics what we are discussing was basically related to bones and fracture and its management. Okay, so there is a portion also lameness. I was thinking about going for lameness, but there is actually very much what can demand for ultrasonography. Okay, so actually I was little bit reluctant, or you can say skeptical, regarding making videos of ultrasonography, because you see I had a fair amount of experience in radiology. That is why I covered the radiology, because I had some confidence, and also I did some research from books and different articles. Then I did all those videos. But regarding the ultrasonography, I have very less experience because I am a field veterinarian. So here ultrasound facility is not available. And what I have studied during my college days, I also did some post-graduation study in ultrasonography, but it was mostly on elastography and all on tumors. Okay, canine tumors. So I have very less experience in ultrasonography, but there are demands in ultrasonography, and I am an artist. I may not know many things, but I can process some information and give it to you. So if you want, I can go for that, but it will be mostly theoretical knowledge rather than very practical, because I have little bit less like experience. Okay, we can go. I was looking at the book. We can go some basics as well as from organ point of view. Each organ we can cover regarding ultrasonography views, but mostly it will be theoretical. Okay, practically you may have to see. If you have much experience, you can comment, or you can share those in my Instagram and I can post it. Okay, all those things if you have much practical experience, or if you find any mistake. But first of all, I will ask your permission that if you want those theoretical knowledge, mostly I can give it to you by reading. I will also learn and I will make you learn. Okay, so please do comment if you want ultrasonography, otherwise I'll go for a lameness. Okay, which is the part of orthopedics. So today enough of this. Today I welcome you to this last class of orthopedics, basic orthopedics. After this, lameness will start. If I will go for lameness. So today we will be dealing with, we have already covered the fractures and management. Okay, now it is fracture healing. This will be the last class. We will discuss what are the types of fracture healing, as well as what are the complications associated with the fracture healing. Okay, before going to the lecture, some formalities. You know this one. If you are new to this channel and still yet not subscribed, please do subscribe. If you like my content, please do share among your friends, colleagues and the juniors, and also do follow me in Instagram. It is kind of more important than Facebook. In Facebook I usually post different cases I get in field pictorially, as well as I explain what are the procedures I followed. But in Instagram I post my notes. The class notes are all posted in Instagram, as well as the video update are posted in Instagram. If you have any doubt, you can ask me in Instagram. I do reply when I get my free times. In my free time I do reply. So do follow me in Instagram. This is the book which I am referring for this class. This is the small animal surgery by Theresa Wells Fossum. All the images also extracted from this book. If you want further studies, do refer this book, and don't worry, I will give the link to the book in form of Google Drive in the description, as well as the class note and the PPT which I am using in the PDF format. I will provide in the link. You don't need to take notes during the class. Okay, please only listen and see, then simply download the notes and add any point if you want. Okay, and for the studies, do follow that book. It's a very good book, this book. So first, before going to the fracture healing, we should know that the blood vessels will supply to the bone. Okay, the vascular supply. There are few arteries which are very important regarding the supplying vascular supply to the bone. First one is the principal nutrient artery. This is the principal nutrient artery. This principal nutrient artery is responsible for the medullary canal circulation. Okay, this medullary canal circulation, you know that during the anatomy you might have seen the nutrient foramina in bones, especially in femurs or large bone like humerus. Through that, this nutrient artery goes into the bone and is supplied to medullary cavity. Apart from that, you will find metaphyseal artery. Metaphyseal artery. This supplies to the metaphysis where the endochondrial ossification occurs just above the growth plate, distal, from distal point of view. Okay, just above the, here will be the growth plate, just above the growth plate there will be endochondrial ossifications. So to that region, to metaphyseal region, this metaphyseal artery supplies. Okay, next is the periosteal arteries. Periosteal arteries, which originates from the soft tissue. Okay, nearby where the heavy fascial attachment, from that this periosteal arteries arise, they supply to the periosteum, because you see this circulation of this medullary canal is centrifugal. Usually the outer one third, this outer one third is not supplied by this medullary canal. Okay, medullary canal blood vessels. So for those, the periosteal arteries play an important role. Apart from that, in young animals you will find epiphyseal artery. This is epiphyseal artery. It basically supplies to the growth plate. To the growth plate. It is found in case of young animals, not in adult. In adult you will find principal nutrient artery, periosteal arteries and the metaphyseal artery. Apart from that, during fracture there are some blood vessels which originate from nearby soft tissues, that is extraosseous arteries. These are very important from fracture healing point of view. Okay, we'll discuss how it's very important. So these extraosseous arteries, they supply all those things to the fracture line. Okay, wherever there will fracture, there are some procedures how it heals. During those stages, these extraosseous arteries will supply to those areas, because the medullary canal or medullary circulation will be disrupted by the fracture. Okay, there is no medullary canal circulation, so the extraosseous artery, those provide circulation to this fracture area, and when the fracture will heal, they automatically regress. Okay, here you can see these are extraosseous arteries. Here these are extraosseous arteries. They are very important in case of the fracture healing. If suppose you have, during surgery you have damaged these soft tissues around this fracture line, then there will not be any soft tissue which can provide these extraosseous arteries. That is why it is very essential to do less and less or minimal soft tissue trauma around the fracture line, so that there will be soft tissue covering, and from there the extraosseous vessels will arise and they will supply to the fracture line, and which in turn will heal the bone. Okay, but there are some implants which can compromise these extraosseous arteries. Okay, so like if you will be using cast, here the fracture is immobilized by cast, or if you are using ESF, they cause very minimal disruption of this extraosseous arteries, very minimal. But if you are using the intramedullary pin, suppose you are not using the right one, or if you are using too thick which touches the medullary canal, suppose here it touches the medullary canal, so for that region the medullary vessels will be disrupted, as well as if you are using too tight or too many wires, then it can hamper the extraosseous arteries. Okay, all those things you have to take care. But you see, when it is the implants are used perfectly, there will be some degree of compromise, but that's all right. Similarly for plates, if you are using plates, you know that the periosteum just below these plates is can get disruption in the blood circulations or vascular supply. If you are using DCP, then this compromise is more. If you are using, for due to the disadvantage of this particular property of DCP, now it is LC-DCP, limited contact dynamic compression plate is used, so that the periosteal circulation can be better than the DCP. Okay, I have discussed regarding the DCP and LC-DCP in the previous class while we were discussing the plate and screw. Okay, next we'll go for fracture healing. Before going to the fracture healing, there is an inflammatory phase. There are some debates regarding whether you should give NSAIDs or any painkillers or anti-inflammatory drugs. You can give, but it should be in limited quantity, because inflammatory phase is very essential for fracture healing, because it secretes some substances. Okay, inflammation releases some substances which helps in fracturing, like interleukin 1 and 6. It is essential for regulation of the fracture healing, regulation of early fracture healing. It also secretes PDGF, platelet derived growth factor. I have already discussed regarding TGF beta while I was discussing the bone grafts. Okay, transforming growth factor beta, it is necessary for the bone healing. It helps in the mesenchymal stem cells proliferation and differentiation. Okay, cell proliferation and differentiation. This particular factor is very essential. It is secreted in inflammatory phase. As well as prostaglandin E1, E2, they are very much essential for angiogenesis. Those extracellular vessels, so they are necessary for angiogenesis and early bone resorption. Okay, all those things are essential. So inflammatory phase is essential. If at all you are not doing anything, don't disturb the hematoma. Usually we'll see the hematoma will, when inflammation there will be hematoma formation. Don't disturb this one. Okay. Next, fracture healing are of three types. Okay, first one is the indirect bone healing. We'll discuss one by one. In indirect bone healing, you will find a cartilaginous precursor, or callus. Callus usually is of two types. Very commonly it is two types. You see, this is the bone. This is the bone. Out one is the periosteum, and this inner one is the endosteum. So when there will be callus formation, callus will arise from the periosteum as well as the endosteum. Okay, so the callus which arises from the periosteum is known as periosteal callus, which arises from the endosteum is endosteal callus. There is also a term called cortical, and this region cortical, but that is not that essential. So remember the periosteal callus and the endosteal callus. Periosteal callus is also known as the external callus. Endosteal callus is also known as the internal callus. Okay, so these two, periosteal callus and the endosteal callus, is formed in case of indirect bone healing. It is the most common form of bone healing. Okay, so you will find periosteal and endosteal bridging callus. Bridging callus means, suppose this is fracture line, you see here is one coming, here is another coming, so it will form a bridge. Here you can see it is forming a bridge, that is known as the bridging callus. The outer external one is the periosteal, the internal one you can see here, the internal one is the endosteal callus. Okay, next is the direct bone healing. Direct bone healing, usually when you will be using DCP or dynamic compression plate, when there will be perfect apposition, there will be direct bone healing. Here you will not find any callus, or if you are there is some gap, then it will become very minimal callus. Absolutely you cannot recognize, especially radiographically. Intramembranous bone healing, it is kind of indirect bone healing, but here what will happen, this periosteal callus, this particular periosteal callus will be minimal periosteal callus. Regarding, if you will say me or ask how the, in which fracture systems, if you will using bone cast or the plaster cast under the cast, okay, this indirect bone healing will occur. For if you are using plate, then this particular direct bone healing will happen. Best example, okay, DCP, here you can say cast. For this one, this particular thing happens when there will be multiple fracture, or you can say comminuted fracture, okay. For this fracture, comminuted fracture, this particular intramembranous bone healing will be there. We'll discuss, okay, in detail, don't worry. Next, first one, the indirect bone healing. So this particular healing will occur when there will be unstable mechanical environment. You see, this is the bone and this is the fracture line. The environment around the fracture line, this is the mechanical environment, and it is denoted as the mechanical strain. Here it is the mechanical strain. It is not bone strain, it is the environment. What is the strain put on this particular environment, okay, by different factors, mostly by bone, is known as mechanical strain. The formula is change in gap width by original width into 100. It is usually expressed in 100%. So suppose here it is 2 mm gap, okay, after you did some cast, applied some cast or any indirect reduction, whatever you did, the gap is now 1.5 mm. So especially the environmental stress will be, or mechanical environmental stress will be in 25%. But you see here, for this particular indirect bone healing, it can occur in a strain up to 100%, okay, up to 100% it can occur. Mostly it happens in most unstable environment, okay. In most stable, it is direct. Here there will be more interfragmentary movement. For this particular healing to occur, you will find in those cases where interfragmentary movement, this movement between these two fragments, there will be more. High strain condition, I told you, it can go up to 100%. In those cases, if it is very high, then be sure that the healing will be through indirect bone healing. Example is fracture stabilized by cast. I just told you. Let's see the procedures, or you can say that the steps. So the first step is the hematoma formation. First step will be hematoma formation. Hematoma. Here I told you, when there will be hematoma or inflammation, all those things will be secreted, like interleukin, PDGF, platelet derived growth factor, or TGF, transforming growth factor, or prostaglandins. All those things will be secreted. Next, this hematoma is kind of very soft. Gradually the tissue will harden. Next, it will be replaced by the granulation tissue. Okay, it is comparatively more stiffer than the hematoma. Now new extraosseous vessels will start proliferating, as well as you will find that there will be bone resorption. Bone resorption happens when there will be increase in osteoclastic activity. Osteoclast is basically a cell which eats bone, or you can say which destroys bone. So why this actually happens? See, I told you the mechanical environment regarding. So body, what will tell? It will try to reduce the mechanical environment. Let me give some example. Suppose earlier there was 5 mm. When you reduced, it became 2 mm, gap between the bones. Okay, so the mechanical strain will be 5 minus 2 by 5 into 100. It is 3 by 300 by 5, which is basically 60%. Now it is 60%. Now there will be bone resorption. Some bone will be eaten out by the osteoclast. What will happen? This gap will increase. So earlier it was 2 mm, you reduced. Now it will get widened. There will be widening of gap in this particular phase. There will be widening of gap. So now it is 3 mm. Okay, now it became 3 mm. Now let us calculate the environmental strain. 5 minus 3 by 5 into 100. It will be 200 by 5, which comes around 40%. Now see the environmental strain, not bone strain. The environment around the fracture bone, the strain has been reduced to 40%. That is basically body will try to reduce the stress or strain. So there will be widening of the bone. Okay, you will see the radiograph. You can appreciate. Don't worry. So after certain time, the granulation tissue will now be replaced with the connective tissue, that is the fibrocartilage. Fibrocartilage. Okay, now over the fibrocartilage there will be mineralization. You can see here the mineralization is starting. Here some mineralization is starting. So mineralization will start from the periphery to center. From periphery, or you can say most proximal or most distal to center. Okay, it will progress like this. The mineralization will start. Then the mineralization, when there will be mineralization, first is cancellous bone which will be formed. Mostly commonly in a fracture healing will be known as woven bone. Okay, like in wool you wove some garments, like that is woven bone. After that there will be further mineralization. It will become more and more hard. It will become the structure exactly like bone, that is known as lamellar bone. You know that bones have lamella. Okay, lamellar bone. It is much stiffer. Okay, see, hematoma is least stiff and to the most stiff. Okay, so lamellar bone. After that you can remove your splint or whatever cast you have given. It is kind of sufficient. But now there is some extra portion and some things are not done yet, like bones. The cortical bones has Haversian system. Okay, Haversian system. And regarding callus is, you can say this is fibrocartilage callus, then the mineralization is the mineralized callus. Okay, all those things. Callus is basically a name given. Okay, it may be of fibrocartilage type or mineralization type. Okay, it is there. From here you can tell callus. Okay, Now, the lamellar bone does not have the Haversian system, especially the cortical bones here. Okay, so what will happen? It will get remodeled, that is known as Haversian remodeling. Haversian remodeling. The last step is the here the medullary canal will also get medullary circulation will be established. Okay, in this particular stage when there will be bone formation. After that, there will be Haversian modeling. What will happen in Haversian modeling? You see, this is a Haversian canal formation. Okay, this is the image of how Haversian canals are formed. It has three parts, or you can say it has a tip which has osteoclast. This is osteoclast. Okay, it will cut through the bone. This canal will be like this, moving like this. Some will moving from the proximal to distal, some will be moving from distal to proximal. Okay, like this they will move and they will form the canals. Okay, in anatomy you have seen the Haversian system, which is found in cortical bone. You can see how it will happen. In the tip there will be osteoclast, it will make some holes. Then there will come the mesenchymal stem cells. These mesenchymal stem cells will differentiate into the fibroblast. Okay, osteoblast. Osteoblast. Then they will secrete the concentric rings. That is the completed Haversian system. Like that, the Haversian system will be established. Okay, extra bones will be eaten out by osteoclastic activity. So these are basically Haversian remodeling. Okay, it can take months to years. Okay, so Haversian remodeling. These are the steps. Remember, first one will be the hematoma, phase of hematoma, then granulation tissue, then the fibrocartilage, that is the connective tissue, then we start with mineralization. First will be woven bone, which is kind of cancellous, then will be lamellar bone, which is true bone, then after there will be modeling, that is the Haversian system, Haversian remodeling. Okay, so these are the basically steps in fracture healing, especially indirect fracture healing. Let us see radiograph. Here you can see a fracture here. Okay, this is the oblique fracture. It has been immobilized by cast. Now see here, there are multiples. You see, when there will be fracture repair, it is not that after this step this will happen. Certain portion might have in certain stage, certain portion will be in another stage. Okay, you don't need to think like that, this after this will happen. Most predominantly this step will happen. So here can you see the fracture gap is actually increased. Okay, though there is some callus is there, but you can appreciate that the fracture gap is increased. Okay, gap has been increased because I told you to reduce the mechanical environmental strain around the fracture. Next you can see the callus formation. Here you can see a callus formation is going on here, and also here the callus formation is going on. Okay, these are periosteal callus. This is bridging of periosteal callus, and the endosteal callus is also growing, that is the endosteal callus. So callus formation is here. Here you can see that, say that in this particular diagram, gap has been widened and there is callus formation. Okay, now the callus has been bridged in this particular, there is bridging callus, bridging. Okay, both the proximal and distal has been joined to form a bridge. The bridging callus is, you can know from radiograph by how the diameter around the fracture line will be increased. Okay, you can see the diameter is too high. Okay, comparatively this one, this is the diameter is increased. This is bridging callus, periosteal as well as the endosteal callus. Now this is the remodeling. You can also see that the medullary canal has been restored as well as some portion has been cut out. This is by osteoclastic activity. Also you can see that, sorry, you can see here the cortical bone is also restored. Okay, the cortical bone is restored. Here there is no differences between cortical and bone marrow because all those things is bone basically. Now the medullary canal has been established as well as the cortical bone has been established. That is the Haversian remodeling. Okay, so this is indirect bone healing. Next is the direct bone healing. Direct bone healing most commonly you will find in case of DCP, use of DCP. Here the maintenance of absolute fragment stability is a necessary condition so that bone can heal directly. Negligible fracture motion, of course, if there will be fracture motion, it will go to indirect. Fragments are in contact or there will be very minimal gap, that is 0.1 mm to 0.3 mm. Okay, so that there will be the mechanical strain will be zero, absolutely in contact. Okay, so when the fragments are in contact, the healing is known as contact healing. Contact healing. When there will be slight gap, it is known as gap healing. We'll discuss. Okay, they will be known as gap healing. Okay, both are coming under direct healing. The example is fracture stabilized with the DCP, dynamic compression plate. Let us see. Here is a fracture which has been immobilized by the DCP. You see the near cortex. This is the near cortex. This is the far cortex. So near cortex there is opposition because of dynamic compression, but in the far cortex there is a gap. For to avoid this gap, you have to do the pre-stressing of this particular dynamic compression plate. I have discussed vividly in the previous class while discussing the plate and screw. I will give the link to the entire playlist in the description. Do check them out. But even if you do your best, there might be some gap in the far cortex. So here there will be gap healing. Here there will be gap healing, and here will be contact healing. Contact healing. Okay. So what will happen in this is the picture of the near cortex. You see these are Haversian systems. Haversian systems. Okay, Haversian remodeling. There will be union as well as reconstruction. Simultaneously, union plus reconstruction. Union plus reconstruction. That is the Haversian remodeling. In case of gap healing, there will be fibrocartilage formation. Fibrocartilage, or you can say fibrous thing, or a fibrous thing will be formed. Over that there will be union and reconstruction. Okay, but it will be very minimal, very thin. It may not be recognized in radiograph. Okay, now there will be healing. These are basically Haversian systems. Okay, Haversian systems. The anterior most is the osteoclast. Below that there will be vascular cells, mesenchymal stem cells, and below after that the osteoblast will secrete the osteocytes. Okay, osteocytes. So these are basically the direct bone healing. Let us see some radiograph. Here the tibia has been stabilized, but the fracture line is not that visible. But you can see the this is the radius only. This is the radius has been stabilized. Okay, but the fracture line is not that visible here. But you can look at the ulna. Okay, you can look at the ulna. You can clearly appreciate that the callus is very minimum. Ideally, I should have shown you this fracture, but it is not that visual. Might be some very good, you can say that very good fracture reduction. So it is not that visible, but you can appreciate this particular ulna. You can see that the fracture has been healed with very minimal callus. You cannot differentiate where is the periosteal and endosteal callus. Okay, so this is basically the fracture healing, the direct fracture healing. Or sometimes you see fracture healing can be classified also primary and secondary. Under primary, direct bone; under secondary, indirect and the intramembranous. Okay, there are some different classification, but basically three: indirect, direct and intramembranous. So intramembranous bone healing, it happens when there will be mechanical, moderate, or you can say mild strain, up to 5% strain. The best example is a bridging plate osteosynthesis. I have already discussed regarding this one. When there will be severely comminuted fracture, you have to simply put a plate which will act a bridge between the proximal and the distal segment. Okay, so bridging plate osteosynthesis, in those cases it will find intramembranous. ESF for severely comminuted fracture also, in those cases we will see some radiograph of ESF. Okay, so in those cases also it will be intramembranous. In case of intramembranous, the healing will be exactly like the indirect, but here only difference is the periosteal callus will be minimum. Okay, this periosteal callus, you can see here it has been comminuted fracture, multiple fractures. The medullary canal has been disrupted, and you can see the callus. This is the endosteal or the internal callus. Okay, the external callus will be very minimal. Okay, now the bone has been formed, the medullary canal has been established, and then after that there will be remodeling, that is the Haversian canal establishment. Okay, this is the image. You can see here, this is a comminuted fracture. It has been stabilized with the ESF. You can see here fracture. Okay, one piece, two piece. Okay, these fractures. Now see the callus formation. See here the callus, you can see some opacity inside the bone. Okay, here some opacity and also here some opacity. These are basically endosteal callus. You cannot see if there has been periosteal callus. You can see a clear bulge. Okay, clear bulge will be there for the periosteal callus. but here there isn't any walls, only the endosteal callus is formed and very minimal periosteal callus. This is basically intramembranous. It is exactly like the indirect, only thing is the periosteal callus will be minimum. Okay, so this is basically intramembranous. There is some other special type like trabecular for the fracture of metaphysis or the trabecular bones or the spongy bones. When there will be fracture, there will be new trabecular bone formation because it is very rich in osteoblast, very fast acting, it will heal very fast. After that there will be bridging of this trabecular bone, then the cortical healing, the cortical cell will heal. This kind of little bit faster. Here radiography will find a white line, or you can say increase in radio opacity at the fracture line. Okay, you can see some radio opacity increased and some callus in between them. Okay, so this is basically trabecular bone healing. Nothing, but only thing is that it is rich in osteoblast, so kind of faster. Next is the physeal bone healing. You see, before going to the physeal bone healing, you should know that the physis has, or the growth plate, basically the growth plate has different layers like germinal zone, proliferative zone, after that hypertrophic zone, zone of provisional calcification. Okay, after that there will metaphysis will start. Okay, so there will be, here will be ossification, there will be endochondrial ossification and the bone will grow. So if there will be a fracture between this zone provisional calcification and hypertrophic zone, here if there will be any fracture here, there is a chance that germinal cell zone will secrete more and more cell and it will heal. But if there will be fracture between this proliferative and germinal zone, which is also known as reserve zone, so if there will be fracture here, then this particular synthetic zone is completely gone. Okay, so what will happen in that case? So I was coming to that point. So if there will be a fracture, usually it is known as Salter-Harris fracture. If type 1 is through the physis. Okay, so when there will be a fracture, if the fracture line goes through this calcification zone or the zone of hypertrophic zone and provisional calcification zone, here if the fracture line goes through here, then the cells will grow. Okay, after that it will fill up the physis. But if the fracture line goes through the reserve zone, that is the proliferative and germinal zone, which is the synthetic zone, so if that particular zone, if it is fractured, then it will simply get ossified by endochondrial ossification and the growth plate will close. Okay, permanently it will close. So for this actually I wanted to highlight, for physeal fracture it can vary depending on through which the fracture line goes. Although you may not appreciate through radiograph that through which it is going, but if at all it is going, then this is how it will heal. Now let us go to the fracture complications. The first fracture complication is the delayed union. Okay, delayed union, it has very vast factors which can be responsible for the delayed union. Mostly if you will see that if this fracture is taking more than 12 weeks, then you can identify as 12 it is delayed union. The appropriate definition is fracture that heals more slowly than the anticipated. When you will take sequential radiographs, you will see that it is not that fast healing, or it is healing slowly. There are several factors which can contribute to delayed union. Systemic status of the patient, if the animal is malnourished or having some anemia, it will get delayed. Nature of the trauma, high velocity wounds usually get delayed, or there is extensive soft tissue injury, first soft tissue has to be revived, then the fracture will heal, all those things. If there is compare between the closed fracture and the open fracture will get delayed. Local host post injury response, like how the immune system of the patient. Also fracture management, if you are doing some poor decision, okay, if you are using some like very thick IM pin, then it may cause some medullary circulation disruption. If there is a short oblique fracture and you are using wire to fix this one, okay, I told you for long oblique you can use orthopedic wire, for short oblique wire is not recommended. For those if you are using, then the fracture will be destabilized, then there will be delayed union. If the implant is unstable, you have not used proper screw or plate, suppose you have to use 3.5 but you use 2.7, okay, the unstable implant, all those things can contribute to the delayed union. Next, pharmacological factors, long-term use of steroid and NSAID for pain management can also delay the fracture, because you know that you need some inflammation for all those factors that can contribute to the fracture healings. NSAID and steroids, they basically block this. These are anti-inflammatory drugs. They will block the inflammation, though the fracture may get delayed. Okay, next complication is the non-union. Non-union. So non-union means arrested fracture repair process. So it is basically because of instability at the fracture site. Radiography will find lack of activity on sequential radiographs. It can be hypertrophic as well as the hypertrophic non-union, and also it can be atrophic non-union, non-union. In case of hypertrophy, the difference is basically callus. In hypertrophy, you will find there will be callus, but still it is not healing. Okay, here you can see some callus formation is also there, but it is still not healing. It is actually unstable. You see, this is a short oblique fracture. This is a short oblique fracture, or might be slightly oblique, long oblique. But see the wire placement. It is not that good. Okay, the wire placement is not that good, not that proper. That is why there is more fracture segment movement or fracture fragment movement may be leading to the non-union. Okay, for this you need again surgery. In case of atrophic, there isn't any callus, no callus formation. Bone appears dead, or you can say sclerotic. Bone appears sclerotic. Okay, sometimes there will be fibrosis of this bone ends. Okay, when there will be fibrosis, nothing will happen. Okay, for that you may need surgery, remove all these fibrotic things, all those things. If there is some sequestra, dead bones, those you have to remove, then again do the implant. It needs surgical intervention. This is basically non-union. It can be hypertrophic, in case of atrophic. In case of hypertrophic, there will be callus, still no healing, but in case of atrophic, no callus, no healing. Okay. Next is the osteomyelitis. It happens when you are not following the principle of asepsis. Okay, so infection can go in, and it can cause osteomyelitis, inflammation of bone and medullary cavity. Microbial infection, mostly bacteria. Most common is the bacteria, although it can be any microbe, most commonly bacteria. Implants and adjacent damaged tissue, the most commonly affect. Radiographically, what you will find? Radiography will find periosteal and endosteal bone formation and bone resorption. It can be both. Okay, loose broken implant and non-viable bone fragment, which is known as sequestra. Okay, here you see, compare these two. Okay, this is the lateral projection, this is the, or you can say this one is the craniocaudal projection, this is the lateral medial projection. So here you can see that, see here, this particular here, the bone has been resorbed, or there is bone lysis, you can say. You can tell that, but around these three screws, the bone has been resorbed. Okay, I told you loose and broken implant, bone resorption on around the loose and broken implant. So around these three screws, the bone has been resorbed. There is new bone formation also here, I told you. And okay, so all these things, okay, non-viable bone fragment, although it is not that visible here, but if you will go, you may find some non-viable fragments. So this bone resorption as well as the bone formation and some loose implants, you can see that the bone around these three screws is gone, so implant will be loose. So all those things can conclude that it might be having some osteomyelitis. You need surgical intervention as well as culture and sensitivity test. After that, you can go for the surgery and something therapy. Last one is the malunion. Before going to the malunion, see, this is the normal bones. This is the craniocaudal view. This is the cranial surface. Towards the blackboard is the caudal. This one is the medial. This one is the lateral. And this is the lateromedial view. Okay, this one is the cranial. This one is the caudal. So valgus is the basically lateral. Lateral deviation is the valgus. The varus is the medial deviation. I told you this one is the lateral, this one is the medial, this one is the lateral, this one is medial, this one is the cranial towards this caudal. This one is the lateral medial view, this one is the lateral, this is cranial, this one is the caudal. So anticurvatum towards the cranial, recurvatum towards the caudal curvature. Next is torsional. Torsional means simply it will rotate towards the axis. Torsional. Translational, bone will be there, distal segment will slightly slide, and this is the oblique things like this. Okay, joint will be parallel. Okay, here it should be here, but slightly shifted. Parallel is slightly shifted. This is translational. Okay, so this is basically different forms of malunion. To correct malunion, the procedure is osteotomy. You have to again cut and join. Osteotomy. This is the procedure to correct the malunion. Okay, so these are basically the malunion, and with this we finish the basic orthopedics. There is a portion lameness, but if you want ultrasonography, please do comment down below. I will look into it, and I may start ultrasonography, mostly the theoretical portion. Okay, so till then, tata, bye bye, take care.